Exactly. Well, thank you very much for the kind introduction, dear Chairman, colleagues, ladies and gentlemen. Thank you very much for the invitation to talk to you today. Well, my topic is, or what we're going to do in the next 20 minutes is that we're going to hijack the respiratory center. Or in other words, we're going to talk about automated ventilation, which means automated end-tidal CO2 and automated tidal volume control. I do have a conflict of interest to declare concerning this topic, as you can see here. Well, so what's the agenda for the next minute? First of all, we'll just have a short summary or overview about automated ventilation. Where is the status quo? Where are we now? Or where have we been, let's say, 1 or 2 years ago? Well, then I'll introduce to you a new development. And last but not least, I'm pleased to say that today is the first opportunity for us to publicly present our first scientific data concerning this new development. Okay, so let's go ahead. Automated ventilation, where are we? Well, frankly, the idea of automated ventilation is nothing new at all, with the first major publications dating back to the early 90s. This is one of the probably most important publications of the time. And they postulated, or they created a closed-loop ventilation control system, and they called it Ganesh. And when I read that name, the Hindu god Ganesh or Ganesha popped up to my mind, and that's why you find this little pink friend here on the first slide. Okay, other publications, other ideas were soon to follow. Well, as I said, it was in the early 90s, more than 25 years ago now. Well, time has passed. Time to gather some data, some experimental data, some more knowledge about these automated closed-loop systems, which generally say, yes, they are feasible, yes, they are working, and yes, they come up or provide us with some advantages. For example, shortening of waiting time in the ICUs. Also, Cochrane reviews are available about these. Well, okay. But I'm going to talk about the past, we're going to talk about today and the future. So let's talk about a new development. The thing is that all of the automated ventilation systems that have been available until, well, very recently, have all been designed for ICU use, not for the operating room. So the idea was, and this was like in the early 2000s, to bring, on the one hand, ICU ventilation, meaning lung protective ventilation in the OR, and doing so by providing an automated closed-loop ventilation system to take over the job. The idea, as I said, dates back to a time where no one or hardly anyone was thinking about lung protective ventilation in the OR. Well, this novel system is called Smart Ventilation Control, and I'll just introduce this system to you, how it works, what it does. But first, we're just going to talk a little bit about what is the difference between respiration or ventilation in the ICU compared with the operating room, with some tasks to be fulfilled when handling ventilation in the operating room. You do not face in the ICU. Mainly talking about changes of ventilatory mechanics, maybe due to altering of the positioning of the patient, due to capnic peritoneum, whatever. Also coming up with changes in VCO2, for example, according to anesthesia depth, to body temperature, and so on and so forth. And also optimization of spontaneous breathing is an area or a field of interest also in the OR respiration. And certainly, of course, optimization of weaning. Well, this is what we have to handle in the operating room when we are ventilating our patient. This is, of course, what also a closed-loop feedback system has to handle in order to do an acceptable or good job. So how is smart ventilation control doing this? Well, first of all, what the user has to do is to tell the system what the patient's height is, because the height is used to calculate the ideal body weight in order to calculate the tidal volumes. The second thing is to set the correct or the wished ventilation goal. I'll come back to that, to these ventilation goals in a minute. And corresponding with the selected ventilation goal, there are predefined target ranges, as you can see, for tidal volume and for end tidal CO2. What the system then does, when it's active, it continuously monitors and monitors and judges the inputs it gets, mainly being end tidal CO2 and the tidal volume, and then it is calculating are these values within the desired ranges or not, and if not, it is automatically adjusting settings, primarily being respiratory rate and inspiratory pressure, in order to bring the ventilation of the patient into the desired corridors again. I've got here a very simple example of how it would do so. As you can see here left on this minitrend, at about minute 10, the tidal volume would be totally within the desired range for the tidal volume, the end tidal CO2 declining and reaching the lower or passing the lower border of the target corridor for end tidal CO2. So what would smart ventilation control do? It would decrease the respiratory rate in order to bring the end tidal CO2 into the desired target range again. Let's come back to the ventilation goals. I've already mentioned them. These are essentially, besides telling the system the patient's height, the only interaction the user has to do or to fulfill with the respirator. These ventilation goals are determined by the user according to the operation, according to the patient's condition. If you want to compare it with an autopilot in an aeroplane, it's not the first comparison with aviation that's been made today, but it wouldn't be me if I wouldn't make one. The autopilot in the plane flies the aeroplane for you, but you still have to tell the autopilot where to go with the aeroplane. And exactly the same is being done by telling smart ventilation control or setting the appropriate ventilation goal for smart ventilation control. These 4 goals are as follows. The first one being called controlled. You can see the predefined target ranges here. It is a pressure controlled ventilation, and it's suitable for a situation where the patient should be ventilated controlled without any support of spontaneous ventilation. Second one being a little bit unluckily being called augmented. It is not augmented ventilation, it is also pressure controlled ventilation, but it's also with synchronized pressure support. So this one would be applicable if you want to ventilate the patient controlled, but spontaneous ventilation is augmented whenever it arises, but it's not actively being encouraged. The third ventilation goal, being called encourage spontaneous breathing, in contrast, is designed for encouraging spontaneous breathing. The main difference being the ETCU2, the predefined ETCU2 corridor being higher, ranging from 42 to 52, in order to induce spontaneous ventilation, in order to induce the respiratory drive of the patient. And the fourth goal, called prepare extubation, it's very similar to encourage spontaneous breathing, plus it automatically performs a spontaneous breathing trial and provides the anesthetist with feedback whether the respiratory drive of the patient is sufficient for extubation or not. So we see that smart ventilation control is capable of managing the ventilation of the patient throughout all the stages of anesthesia, ranging from intubation until the moment you pull the tube out again. Okay, just one short example of how smart ventilation control looks like in actual using it. You see here we are in the ventilation goal controlled. You see pressure controlled ventilation, the ETCU2 being with a 37, perfectly within the desired target range, which is shown here as this little green bar. The tidal volume with 420 milliliters also being classified as being perfectly normal for this patient. On the bottom left, you see those little mini trends here. There you see the course of the last 30 minutes of the smart ventilation control session with the classifications of tidal volume and ETCU2 respectively. Okay, now let's go ahead. As I mentioned, you'll be the first one to hear our first gathered scientific data concerning smart ventilation control. We did a trial called the AVAS trial. It was a bicentric study together with the University Hospital in Kiel in Germany. We included in 100 patients who underwent elective limb or peripheral vascular surgery. And the airway was managed either by endotracheal intubation or by laryngeal mask airway, depending on the clinical situation. Just a few words about our data management, because this is something we're quite proud of. We continuously recorded all respiratory as well as hemodynamic data, with the most important being recorded about every second. So we've got a value for tidal volume, a value for EtCO2 whatsoever every second, which makes up of about 750,000 single data point for each single parameter. Okay, what were our endpoints? It was just a feasibility trial or proof of concept study. We didn't have a control group. We just performed ventilation with smart ventilation control on these 100 patients. And the endpoints were as follows. First one being severe hypoventilation, defined as a minute volume being less than 40 milliliters per kilogram for more than 5 minutes. Second being apnea for more than 90 seconds. Third one being hyperventilation, defined as EtCO2 being more than 5 millimeters of mercury below the lower limit of end-tidal CO2 target corridor. Then hypoventilation, defined exactly the other way around. Tachypnea, defined as a respiratory rate of greater 35 breaths per minute for more than 5 minutes. And last but not least, the override by the anesthetist in charge if the clinical settings for the ventilation were not acceptable or even unsafe for the patient. So what were our results? We had some adverse events. We had 14 events of severe hypoventilation, 12 of hyperventilation, 4 of hypoventilation. These 14 here being defined by the minute volume. I'll come back to that in a second. We didn't have any apneas, tachypneas, or any override by the anesthetist in charge. And these events could, they happened, but smart ventilation control was capable of managing them and bringing the patient back into the desired corridor again. So let's have a look about our 14 severe hypoventilations, again as defined by a low minute volume. How did these happen? Well, easily explained. We did go ahead and perform the transition from controlled ventilation to augmented spontaneous ventilation during the operation or during the anesthesia for every patient. We had a quite strict protocol to do so. So sometimes we did it at a time where the anesthesia depth or maybe analgesia depth or opioid load was not really adequate for bringing the patient to spontaneous ventilation. So what happened? The smart ventilation control did what it is supposed to do. It reduced mandatory frequency, therefore absolutely decreasing the minute volume. That's why the endpoints occurred. But as you can see, we do have a minute volume lower than 1 minute, but still the EtCO2 in this example is within the desired target range, and also the tidal volume is classified as being normal, so also being within the desired target range. And as you can additionally see, the saturation or the oxygenation is not impaired at all. We've got a 97 O2 sets with a FiO2 of 35. Okay, the second quite frequent adverse event was hyperventilation. Just to remind you, defined as EtCO2 being more than 5 millimeters of mercury below the desired target range. How did this occur? Well, again, with spontaneous ventilation. Patients that were breathing perfectly normally, spontaneously during the anesthesia, and their respiratory center told them, okay, I want to have an arterial CO2 tension of, let's say, 14 millimeters of CO2, representing an EtCO2 in this example, let's say, of 34, which is perfectly normal and physiologic, but still it is way below the target corridor in this ventilation goal, which ranges from 42 to 52, to remind you. And this is why it is classified as severe hyperventilation. This is why these endpoints occurred. Okay, as I told you, we've got a whole lot, big data, and I'll just provide you with some descriptive statistics of the main respiratory parameters we recorded. Let's start with the tidal volume. We had a mean tidal volume of 6.5 milliliters per kilogram ideal body weight, produced by a mean inspiratory pressure of about 14. We used usually minimum of 5 PEEP, sometimes a little bit more, but at least 5 PEEP, so driving pressure would be the mean driving pressure less than 10. Secondly, of course, very important, the end-tidal CO2. We did have a mean end-tidal CO2 of 41, and a mean respiratory rate. This is only the mandatory or the mechanical respiratory rate, not the spontaneous respiratory rates. We still have to calculate them out of our data. And what we additionally did is to do an arterial puncture in order to obtain one arterial blood gas. We did so 15 minutes after incision. At that time, most of the patients, or I think all the patients, were under controlled mechanical ventilation, under individual controlled or augmented, and the mean arterial CO2 being 43 at that point of time. Sounds all very good, but of course there are some clear limitations for this closed loop system. First of all, being those published by the manufacturer. I don't talk you through it, you can read on your own. To my opinion, not all of them make sense, but they are as they published. What we did find as clear limitations are those situations where the variables put in, or those source variables for the closed loop algorithm, being mainly end-tidal CO2, secondly tidal volume, are not reliable. For example, ETCO2 in an event of hemodynamic instability, of elevated physiologic dead space, and so on and so forth. Just following the old saying, garbage in, garbage out. The system relies or is based on end-tidal CO2 and tidal volume, and if the measurements which are put into the algorithm are not reliable, the system cannot provide any reliable or good quality ventilation. And secondly, what also happens sometimes is, as I said, when you choose the wrong point of time for the transition from controlled to augmented spontaneous ventilation, for example, inadequate anesthesia depth or opioid overhang or whatever, patients might end up with very irregular spontaneous ventilation with some very small spontaneous breaths followed by huge spontaneous breaths, and this is also something which quite well mixes up smart ventilation control, and it has got a hard time managing those irregular ventilation. But well, it is a closed loop system, it is an expert system meant to help you to provide good patient care, to provide good quality ventilation. It is not meant to be better than an anesthetist or even replace the anesthetist. That is important to keep in mind. It helps you to reduce workload. It helps you to provide good quality ventilation without having you to look and interacting with the ventilator all the time. But of course, it cannot replace the human anesthetist. Okay, so let's sum up. Intraoperative closed loop and tidal CO2 and tidal volume control systems can or are feasible, are safe, help to provide lung protective ventilation, and facilitate spontaneous ventilation and weaning. And I'd like to close with a quotation I really do like. Looking 10 years into the future, one can easily imagine an anesthesia robot in every operating room, endoscopy suite, and so on, delivering anesthesia care with anesthesiologists focusing on other patient needs. This one was published in 2009, exactly 10 years ago. We do not have this anesthesia robot yet. We do not have interoperable closed loop systems, but we have made our first steps, and we will make further progressions and improvements. And as Dr. Goldman said yesterday, if we form a coalition of the willing, we will find the right tools, or we will develop the right tools to provide better patient care. thank you very much for your attention. I'll be happy to answer any questions.